truck, we were called to an 18-year-old female who had dislocated her knee during basketball practice. We arrived on scene to find the individual located in a wheelchair, leg extended with ice located on the injury. We conducted a primary and basic secondary assessment before administering and implementing any treatment options. Throughout CSB 331 and 332, we have learnt a variety of skills which have helped me to be able to assist the patient in reducing mobility to the leg for transportation and comfort, as well as administering pain relief. Although we have practiced immobilization throughout practical stimulations, this was the first patient that I had the opportunity to apply a vacuum splint. I have also practiced the administration of methoxyflurane in scenarios. However, this patient was the first patient that I questioned and assisted in explaining administering methoxy. This included getting the history, gaining information, and assessing the pain. So far in my clinical practice, I have yet to encounter another sporting injury. However, I have been to cases where methoxyflurane has been administered and since attended cases where a vacuum splint has been applied. My skills and knowledge that helped me to deal with the incident was notably my ability to assess the patient and gain information through sample, as well as assessing her pain through OPQRST. We were able to monitor her vitals to make sure there was no significant variation throughout the treatment and transportation process. When looking into the incident and factors underlying the incident, I think it's important to consider the two main treatment options put into place for the individual, these being the administration of methoxyflurane and the application of the vacuum splint. When looking at both of these, it is important that we are aware of the correct procedure under the Queensland Ambulance Clinical Practice Manual of administration and application. Firstly, we administered pain relief for the patient. This was due to her discomfort and high pain rating. With no medical history of any concern, as well as no known allergies, we were able to administer methoxyflurane with it being indicated for pain within the CPM. With the contraindications not relevant to the patient, 3 ml of methoxy was given to the individual during transportation, with the patient being instructed to inhale and exhale gently throughout the mouthpiece. We then informed her that she had the option to cover the dilution hole with her fingers to increase concentration. We then immobilized her leg to decrease any further movement through the application of the vacuum splint. This allowed for the stabilization of the injury as outlined in the CPM by removing all air from the device. A vacuum splint was indicated for this patient due to the dislocation of her knee joint. Through reviewing the case, I have developed knowledge that will assist and aid my future practice as a paramedic, as well as being able to identify different situations that could have impacted on this case, notably communication barriers. Effective communications with patients is critical for the safety and quality of care provided by all team members, as outlined by Paul Schneif's article published with the US National Library of Medicine in 2007. He outlined that these barriers can include differences in language, culture, or low health literacy. When reviewing patient care as a whole, it is important to consider the effect communication barriers can have on patients as well as clinicians in achieving fundamental patient care due to diversity within society. Interactions between paramedics and patients rely heavily on effective communication to gain pertinent information about the situation. When relating back to the situation explored previously, it was observed that pain management was a critical element in ensuring patient comfort in the pre-hospital setting. When putting two explored areas together, we can start to discover the effect communication barriers can have on determining pain ratings, which can in turn affect pain relief administration. As stated in the pre-hospital pain management article produced by the National Association of EMS Physicians, pain is the most frequent symptoms in patients, covering a wide variety of injuries and illnesses. Paramedics rely heavily on patient perceptions of pain to interpret individual suffering and allowing the most appropriate emergency interventions required, as stated in the Emergency and Trauma Textbook, page 413. When an individual patient is not able to effectively communicate their pain to paramedics, it can have adverse effects on patient care for all involved. It is important to understand that patients may have difficulty describing key components of their pain due to language barriers, cultural differences, cognitive impairments, or other psychological or psychosocial factors. Recommendations within the textbook on page 413, where self-report is unavailable or unreliable, states that it is important to seek evidence of pain-related behaviours, evidence of potential causes of pain, and to use estimates of pain by others such as carers and relatives who can describe changes in patient behaviour that may be associated with pain. After exploring the effect communication can have on pain management, it has allowed me to recognise that not everyone we treat or assist will have the ability to clearly communicate his or her pain. If communication barriers were present in this case explored above, it could have had the ability to affect treatment options as stated in 407 of the Emergency Trauma Textbook. Pain is a highly personal experience, and the perception and expression of pain is influenced by factors that include prior pain experience, culture, gender, coping strategies, expectations of care, and the social environment in which pain occurs.